Welcome everyone. My name is Noah. I'm a last year medical student here in Brazil, and today I have the pleasure of co-discussing with Rabih. We are looking for a case, and we'll wait for as long as we have to find one. So if you have a case and you want to present, go ahead, type it in the chat.
I'll admire that, Noah, as long as we have to. I love it. Oh my gosh, yes. Today is Noah's first discussion, which is awesome. And I think, Noah, there's a friend in the chat who is meeting your request. Mingyu, hi. It's nice to see you.
Yeah, hi. Very nice to come back after a week of teaching service and being.
Oh yeah.
Yeah.
How was it?
Yeah, it was nice to be working with the trainees and having a lot more time for reflection.
Amazing.
And actually going to go back to a teaching service next week with the new interns, so very excited.
Oh wow. Wow, that's awesome. So you get 1 week for non-clinical time in between. Is that how it works?
It just happens to be because I have some travel in July, August, so kind of
I see
everything together.
Amazing. Well, thank you for joining us, and thank you for presenting this case. I personally think that cases without a clear final diagnosis are the most ripe for learning, in large part because they're so close to reality, but also maybe because even if an answer is eventually released, it's so cool to see how that evolves in real life, and for you maybe to follow up if there is any resolution in the future. So that would be really, really cool. Yeah, I think we're ready to rock and roll. You good, Noah? Awesome. Okay. All right, man, you take it away whenever you're ready. I think Aisha is scribing today and Leah is doing teaching points, so we're in for a treat.
Yeah, I also think it's kind of a great opportunity for me to kind of consult Rabih and the CPS community for the diagnosis. And I think there's a lot of room to improve how I approach this case. Sometimes I wish I have someone at work like Rabih or our community or Gurpreet, or someone who I can just call to discuss, but I don't have that person in my work environment. But I'll also say I'll present this case authentically, how it presented to us. As with many other cases in the real world, our first impression of a patient is often their medical chart before we even got to see them. So the patient is signed off to me by my colleague who said he accepted a transfer from outside hospital emergency room, and the patient will arrive sometime overnight. So the story what we got was that this is a 47-year-old man. The reason for the transfer is further workup for AKI and suspected pulmonary embolism. So the patient presented with 1 to 2 weeks of fatigue, some dyspnea and chest discomfort. At outside hospital ED, he was found to have an elevated D-dimer of more than 3, normal is less than 0.5, and a new creatinine elevation of 2.44. So they wanted to assess for PE with a VQ scan, but they don't have that capacity. They also wanted to work up for AKI, but also didn't have ultrasound at that time. And because his vitals were normal, the ED physician doesn't think the likelihood is high enough to start empiric anticoagulation. His past medical history is most only notable for a sleeve gastrectomy 6 years ago, some ongoing GERD symptoms, but negative EGD colonoscopy recently, and hypertension. I also give what the labs we have at that time. Creatinine is 2.44. A year ago it was 0.95. BUN 42, D-dimer more than 3. Bicarb 21, potassium is 4, sodium 131, hemoglobin 15, white count 9, and troponin is non-elevated. Chest X-ray and EKG reportedly or normal. Yeah, I think I'll stop here. I have like about 4 to 5 aliquots in this case.
Okay, so we got a lot of information right on the first aliquot. I love this style of presentation. Like we kind of feel like we're going to see the patient right now. So we have a 47-year-old male with AKI and this dyspnea syndrome with an elevated D dimer. I was just watching a past video from Clinical Problem Solvers. It talks about connecting the dots. So we have like two kind of different informations here. We have like a kidney problem and we have a dyspnea problem. And we have to think, is one leading the other, or is something underneath the surface that's connecting both of them, that's causing both of them? And my suspicion in this case, because I can't think of any underlying syndrome, is for something to be hidden, and it's causing both the AKI and the dyspnea with elevated D dimer. So the AKI, the way I like to think about it is we can have a problem before the kidney, so hypovolemia or hypoperfusion. We can have a problem with the kidney, so glomerulonephritis, for instance, and we can have a problem after the kidney, so post-obstructive AKI. And we basically triage for the pre-renal and the post-renal first, because they're the easiest ones to rule out. We can do a simple beta scan to see if there's any obstruction and retention. And then we dive in the intrinsic renal causes. With the D dimer and the chest pain, the dyspnea, PE may be a possibility. I agree with the other physicians having getting a D dimer because it is a case that raises some questions if PE is the diagnosis. So we wouldn't jump straight into the CTP, even if the patient had a baseline creatinine, a normal baseline creatinine. And I think a VQ scan is a good next step. Now for the labs, I don't see, I can't dissect it any further, to be honest. We can see the AKI, we see some hyponatremia, but I'm not too concerned about that, probably because of the AKI. And what do you think, Rabih?
Yeah, I think that that you've basically cooked the whole dish, and I'm just admiring what's left over, honestly. I think I really appreciate how you were methodical in your approach to AKI pre, intra, and post, but also practical in that you don't think that it's worth diving into the intrinsic renal category in most patients on day one. I think that's absolutely superb. And I think that if you try to read between the lines as to what the focus is on the thoracic dimension, which is that there's a dangling D dimer, and I think that we don't know what the patient's journey was through their dyspnea and chest pain approach, what the EKG was, what the chest x-ray was. And I'm sure we'll have our own data to analyze about those things in a second. But I'm saying all this because we really put a lot of trust in the patient and the providers taking care of our patients for good reason. They have worked really hard and have had extensive training to be where they're at. And if their working pivot is a dangling D dimer, that tells you with some degree of certainty, though not perfection, that the rest of the workup wasn't too impressive. And so for me, I'm just tracking my mind and curious why it was so much more pivoted towards trying to understand the creatinine rather than understanding the dyspnea. And it's in large part because of the idea that if somebody is emphasizing a D dimer to you, it might imply that the rest of the workup was relatively underwhelming. And it's also true that the specificity of a D dimer for badness, thromboembolic badness, be it in the aorta or the pulmonary artery, the specificity is so low that I think I would not be surprised if we end up saying the chest stuff is just NOS and the kidney dysfunction is really what we have to explain. Truth be told, the rate of venous-related contrast-induced nephropathy is so low that my own personal practice, I have very little instances where I don't scan somebody who I would have scanned otherwise for pulmonary embolism or anything. So I think that we certainly should be very mindful of when we get a CT with contrast in many patients. But I literally do the exercise of if I would scan this patient without knowing their creatinine, does the creatinine change my management? And more so, the answer is no. Because if an untreated pulmonary embolism continues to remain untreated, I'm much more confident that the subsequent hemodynamic effects on the kidney of undiagnosed or untreated thoracic badness is going to have much more consequences on the kidney than the hypothetical concern of contrast-induced nephropathy. So if you practice refining your skills on when to give people contrast in general and get better and better at that, then you will find yourself realizing that the disease that you are looking for is more likely to cause kidney dysfunction in its end course than the hypothetical concern contrast will. So here, if it's true that this is a young, otherwise healthy man with absolutely no explanation on the basic workup for his shortness of breath or chest discomfort apart from a D-dimer, I think the decision to get to assess for pulmonary embolism is not a hard one. And in my practice pattern, this would just mean a CTPE, because you're seeing what the delay and the transfer and all the consequences can have on patient care. But I agree with you. I think the kidney definitely needs to be explained. I'm really curious what happens with the chest. And we can do a fun diagnostic nerdy exercise about trying to connect a sleeve gastrectomy with AKI, but I don't think we would be doing that right now in real life, so we can hold off and do it when it feels more appropriate. Any other thoughts come to your mind, Noah, before we hear more from Mingyu?
No, not really. Just the hypertension. I mean, he's 47, which is kind of around the age we would expect hypertension, essential hypertension to start showing. And he probably has some kind of metabolic syndrome with this sleeve gastrostomy in the past. But I would be curious, just check when he was diagnosed with hypertension, because he may have another cause, a secondary cause of hypertension that's also driving this now unmasked AKI, if it's like it was diagnosed in a very young age.
Love it. All right,
Yeah.
Mingyu, tell us more, please.
Yeah, amazing discussion. So we were also curious, what's going on with the patient. So the patient now arrived, and so when I saw the patient, he already settled in, was kind of sleeping. So I almost feel bad for waking him up, but I think that's a challenge overnight. Sometimes you have to really force him up. And he reports he was active and high energy at baseline, but for the past week had progressive fatigue, walking from the bed to the bathroom would just wipe him up. It sounds like that's what's most concerning to him. He also notes some epigastric pain and tenderness that's new from baseline, his baseline dyspepsia symptoms, which he attributes to his chronic dyspepsia from sleep gastrostomy. He's unsure if that's related to food or because he has poor oral intake, 80% less from baseline. Although he continues to drink fluid. He hasn't taken any OTCs for the pain. And on the day of presentation, he also noted some soft blood pressure in a 90 systolic, so he skipped his blood pressure meds. And when asked if there's any chest pain, he said there's some chest discomfort, but not chest pain. And he did say he has weight loss. No, excuse me. He doesn't normally weigh himself, but he did notice a 30-pound weight compared with 3 months ago. 30-pound weight loss compared with 3 months ago. Medication he's taking famotidine for the GERD, losartan, metoprolol for hypertension, bupropion for depression, and hasn't taken any NSAIDs. He's a manager at a taco restaurant, hasn't worked for the past week due to his symptoms, and no history of clot or recent long trip. His family history is notable for father with pancreatic cancer and some siblings, 2 of the father's siblings with thyroid cancer. I'll also give the exam, vitals 36.7, heart rate 102, blood pressure 107/73, respiratory rate 18, and 99% on room air. He's in no acute distress, no lymphadenopathy, heart is regular, no murmurs, lungs are clear. There's some tenderness over the epigastric left and upper abdomen, no rebound. It was somewhat limited by his body habitus. no peripheral edema, mental status was normal, and no neural deficits. I think I'll stop here and see if we have any additional thoughts, especially with his main concern.
So we have a 47-year-old male with a past sleeve gastrostomy, GERD, and hypertension that comes in for acute fatigue, neo-epigastric pain, and was found to have an AKI on labs. I don't know. I mean, abdominal pain, very unspecific, can be just from his poor status. The low blood pressures can be due to decreased ore intake. They can have something to do with the AKI. System one thinking, I was just, trying to connect the dots. Maybe some aortic process can connect all of his symptoms, like the low BP, the AKI, and the fatigue, the chest discomfort. Also, system one thinking, family history, dad with pancreatic cancer, father, siblings with thyroid cancer. We think of demand syndrome, right? I forget which one it is, but we can have some familial diseases or genetic causes of cancer. Although I don't get the feel that this patient has something to do with this family history. And the exam, very, kind of unremarkable. We have some big, borderline tachycardia, some soft blood pressures, probably because of the underlying disease process. The abdominal exam, we can't see much. And I don't know. What do you think, Rabih?
I think the space that you're in is very similar to the space that I'm in, and I'll try to articulate why. But I would, I love my job in that I get to meet patients the moment they come in contact with the healthcare system, the moment they come into the emergency room, and I think there's a lot of value in understanding and studying that moment. It's a little bit lost in terms of its diagnostic value, I think, when a patient's transferred between hospitals. But I do think that seeing a patient asleep and having to wake them up is not an insignificant finding. If you cannot wake them up and they're asleep, that's a big, big deal and very concerning. But if they're sleeping, I think you can ask yourself, what is the probability of pulmonary embolism in a patient who is asleep? And I don't know the answer to that. I'd be really curious to reflect on it. And this is a shame that there are really almost no studies in the world of diagnosis like this. But you can certainly make an inference on the index of severity of the clinical concern if somebody's able to actually fall asleep in the middle of it. And for me, I'm in the exact same place you are, Noah, because it's really hard to know what the core problem is and what the consequences are. It's almost like you have a patient who has a wound after some trauma, but it's all soiled and dirty. And for you to really understand and be able to look at the anatomy and be able to suture it back together, you need to irrigate it. And I think there's so much dust here that it's hard to see what the core problem is. What are the things that we're tracking? His blood pressure is softer than it was before, but that happens very commonly. His kidney is much worse than before, but he may be dehydrated. He's having epigastric pain, chest pain, and fatigue, and he's lost 30 pounds. But the kidney may actually be the cause of all that, or maybe the consequence of something going on in his abdomen. So where would I stand? I think that the key things are going to be the basic stuff. What is his EKG? What is his chest X-ray? And what happens to his creatinine and fluids? And I think that latter thing is the most powerful variable, because if he continues to have marked kidney dysfunction with a normal bladder scan and kidney dysfunction despite fluids, then all of a sudden you have a very, very robust thing to anchor on, which is a high probability of intrinsic renal disease, which makes everything else potentially connectable to that. If your kidneys aren't working, it's very easy to see how you just wouldn't feel right. Wouldn't feel right that you might be tempted to say it doesn't feel right here in the stomach or the chest, but you just don't feel right overall. And I think that's the tension that I'm having in this case. And it's a tension that you should have because there is no acute emergency that mandates that you proceed quickly or that you proceed with any empiric therapy right now apart from fluid. So the uncertainty here is, I think, inherent to the case. And the key thing to recognize about uncertainty is how long you can live with it is a function of how sick the patient is. And I'm very happy living with that uncertainty for a few hours to see what his creatinine does with some fluids, or to retrieve that information if it's already been done at the other hospital.
Yeah,
All right, back to you.
exactly, Rabih. We were also not totally convinced about PE. At least there was nothing we could do overnight anyway. We don't have VQ scan. And so we got some labs, and so I'll give you the lab. CBC, white count at 7.1, hemoglobin 13.7, platelet 151, sodium 130, potassium is 3.9, bicarb 19, creatinine is 1.92, AST is 48, ALT is 66, normal bilirubins, and TSH is normal. INR 1.26, normal, APTT, D-dimers 4.2, normal was less than 0.5. UA showed a little bit ketones, but otherwise normal. COVID negative, EKG was normal again. And so yeah, we went ahead and decided to give him some fluids and see what happens. So the next morning, creatinine improved to 1.89, improved a little bit. So I guess I'm curious what you think, what you would do at this point for the next step of workup.
Yeah, so very unremarkable still. The improvement of creatinine is good. I mean, there was some component of poor PO intake probably exacerbating this acute kidney failure. I'm interested to see the bladder scan to see if there's no obstruction, maybe do a renal ultrasound as well. And I don't know, Rabih was saying that we have a lot of uncertainty, and what stands me out in this case is that we have like a lot of minor stuff going on at the same time. We don't have like a big thing and something we can focus on. And I think a good way to resolve this conflict is focusing on the most objective piece of data that we have, which is the AKI. So I would probably start the investigation for intrinsic AKI if the creatinine doesn't go down to baseline or if it plateaus in a couple of days. One thing that I saw in the chat, which I think it's worth mentioning, is endocrinopathies can cause those symptoms, maybe adrenal insufficiency. We don't have any other grounds to say that, but it can cause abdominal pain, it can cause the weight loss, the low blood pressures, but I don't see any way to tie like a single pathology to his presentation at the moment. What do you think?
Yeah, no, I'm so impressed because you're literally discussing an unknown case for the first time. And I think there's such a powerful force that pushes you to try to get as much information as you can, which often pushes people to try to pretend that you can get more juice out of what there is. And I think your conversation is going a level above that, and being able to articulate that we can't make much progress, I think is very, very powerful. And I commend you for that. I think the problem with how we're taught to think about cases is we think that the disease and its signature begins the patient shows up to care. But let's rewind the clock and say for 1 to 2 weeks. This patient for 1 week, let's say, has had fatigue for sure. Okay, for 1 week, something happens that causes him to have fatigue. That very thing that caused him to have fatigue takes his creatinine, presumably from normal, which it could have been abnormal before, but we have to make some assumptions to try to at least paint a narrative. So let's assume he has creatinine of 0.95 1 week ago, gets fatigued. His kidney dysfunction then skyrockets to reducing his GFR by over 50%. And then he comes to the hospital. And in the hospital, he's given no treatment at all for his kidney dysfunction, except presumably holding his medications, the losartan, and giving fluids, and his creatinine starts to go in the other direction. So whatever this disease process is that caused this kidney dysfunction over a week is so easily modifiable and so easily fixable. You may be wondering, well, wait, it's not that much better. And I agree. It's not much better because the creatinine is only 1.92 after fluids, but presumably it went from 0.9 to 2.44. Why isn't it 5 or 6 or 7 now? Why is it going in the other direction? And to me, that helps reformulate the assumption that we just made to say, wait, did this problem really begin a week ago? Because if it really began a week ago, his creatinine went from 0.95 to 2.44. Why is it so easy? Why is it so easy to fix? So then you look back and you're like, well, wow, his electrolytes are pretty compensated. Has this problem been going on for much longer? Are we dealing with subacute kidney dysfunction rather than AKI or SAKI? And I think so. And so that's where the investigations for intrinsic renal disease are even more productive, because guess what? All CKD by definition is intrinsic renal disease. You can't have pre-renal or post-renal CKD. You can have pre-renal or post-renal contributors, but by the time there's CKD, it's involving the kidney itself. So I think a renal ultrasound, protein analysis, urine analysis will be very, very helpful. And at this point, I think, Noah, you can start to say, well, okay, this is probably subacute or maybe chronic. You already mentioned hypertension as a potential link, though hypertension causing CKD is a debated topic in the literature. So can you think of any ways that you can connect his sleeve gastrectomy to kidney dysfunction?
No, to be honest, I can't think of any. Let me. What is sleeve gastrectomy?
Yes.
I don't remember.
I can, yeah, please look it up. I can give it a shot. So basically there are multiple forms of bariatric surgery for presumably obesity, and sleeve gastrectomy is one of them. It's basically a surgical procedure to reduce the size of the stomach and helps with obesity. And, many of the consequences of sleeve gastrectomies or any gastrectomies are anatomical issues like marginal ulcers or internal hernia, so anatomical issues. The other big thing, which I think we've had quite a few cases from, is nutritional deficiencies, ranging from very common things like B12 deficiency to less common things like copper deficiency. It's actually very interesting. Sometimes you can get hyperabsorption syndromes, so not deficiencies, but excesses. Those excesses occur from your inability to modulate absorption. So what kind of excesses can happen? One, you can get alcohol intoxication very quickly. So patients with bariatric surgery, if they drink alcohol, they get intoxicated at much lower amounts because of the rapid absorption of alcohol in the stomach. And you can also get hyperabsorption of oxalate. So what happens is, because of fat malabsorption, you chelate calcium. Calcium is stuck in the fat, and that results in oxalate no longer being chelated by calcium. It's a double negative. So at baseline, calcium in the gut chelates oxalate, limiting its absorption. But in patients with a gastric bypass, their fat malabsorption chelates their calcium, which prevents calcium from holding on to oxalate in the stomach. And so you get oxalate. Nars back, y'all. What? Why are you barking? So you get oxalate absorption in the blood, and that can cause calcium oxalate crystals in the kidney, which presents as subacute kidney dysfunction. Long story short, I think it's time to investigate the intrinsic renal causes, and the best way to do that is with a UA and an ultrasound, and to keep in mind the 5 things that show up commonly that are intrinsic renal diseases, and they're of the 5 Ps. So platelets, make sure the patient doesn't have low platelets causing MAHA. Pigment, make sure the patient doesn't have rhabdo or hemolysis. Paraprotein, SPEP or serum free light chain analysis to make sure the patient doesn't have myeloma. Pharmacy, to look at the medications causing interstitial AIN, which the patient doesn't have. And then finally, could have, famotidine has been linked hypothetically to AIN. And then the last P is pointy things like crystals, which here the oxalate crystals would be something to think about. So the 5 Ps are platelets, pigment, paraprotein, pharmacy, and pointy things. I say them in that order because the platelets, pigment, and paraprotein are much easier to test. Pharmacy is a tough one because the links are weak. And then pointy things, crystals are hard to diagnose. You really need sometimes a renal biopsy and occasionally a very astute nephrologist to see a lot of crystals on the urine. Yeah. Any questions about any of that, Noah?
No, I think it's great.
Awesome. All right, now you tell us more, please.
Yeah, the next aliquot, I guess, is a little bit information rich. So the next morning we handed the case to the day team. I guess also on the morning lab, I noticed, which I didn't notice at first, is on the white cell differential, the lymphocyte is 60%, and there are many atypical lymphocytes. I think the reason I didn't notice it that overnight they didn't do like an automated diff. So like it only showed up on the morning lab where like the lab did an automated diff and mentioned like this many atypical lymphocytes. And the day team also decided to get a CTA chest and abdomen to first rule out PE, but also for concern of the cancer history and his symptoms of weight loss. They were concerned about the cancer. So they got the CTA chest and abdomen. It showed actually showed splenomegaly measuring 17.5 centimeter. There's the gastric left band is present without evidence of complications. And then there's no suspicious mass or lesion or metastatic, any evidence of that. And then my colleague and their team called radiology to see if there's something that could explain the abdominal pain. And so the radiology did an addendum saying there's like subtle low density, there's like a subtle finding of 2 centimeter wedge-shaped area of hypoperfusion at the superior aspect of the spleen, which could represent an age-indeterminate splenic infarction. I'll stop here.
Noah, you finally got something to latch onto. Really good job waiting for the key of the data. What do you think now?
Very interesting. I like the CT chest and abdomen. I think it's a good decision. We didn't have that much information before. So we have splenomegaly and we have a splenic infarction. Okay, let me just clear the air, clear my head, because I'm thinking, without meaning to, I'm jumping the gun and I'm thinking already like about specific etiologies. And one thing that I can tie it all together is with endocarditis, because it can have splenic infarctions, it can cause very unspecific symptoms. We don't have like a lot of inflammatory response, but I don't know. And it can cause AKI. So I just wanted to get this out of my system. Splenomegaly, we can have it be like functional, so like a spleen that's, destroying too many red blood cells or too many platelets. We can have infiltration with either infectious process like the endemic mycosis, or we can have some genetic causes of splenomegaly. The septal infarct, though, I do feel like that's the thing we should latch on, but I don't have like the knowledge of specific etiologies. I would have to go on the CP Silver's website and pull up the splenic infarction schema to give me some ideas. The atypical lymphocytes, 60%, I don't know what value we should give to this information. I think the splenomegaly is the most pressing concern, so I would focus on that for now. And Rabih left me.
No, I heard you. I was listening to I had you in my ear. I just wanted you not to hear the argument Nar was having with his neighbor. They were debating what's going on in this case, and they were doing it very loudly. So I I put him away. Yeah, I agree with you. I think latching on to the splenomegaly is my first instinct too. And I think that your approach to tackling this data was wise. You admitted that this is not a situation, not a combination that you're very, very familiar with, nor should you be. It's something that's less common. But you separated them. You said splenic infarct makes you think of endocarditis, and then you said splenomegaly, and you gave a comprehensive differential diagnosis for that. So let me try to set the stage for splenomegaly. Actually, I'm just realizing it's 40 minutes in, so I'll just do the shorter version, which is that you can infarct your spleen in one of two ways. You can have an acute arterial ischemic event like a stroke, or your spleen can grow so big that it auto-infarcts itself. So the key question in patients with splenic infarct is to ask, is it occurring in the context of splenomegaly, or is it occurring in the absence of splenomegaly? Because remember, infarct is just supply-demand mismatch, and here the cause of demand is very obvious. The spleen is massive. And so in most cases, splenic infarct just turns into splenomegaly. And analyzing splenomegaly is really important to have a broad DDX that you said, though a very powerful filter is to see what the CBC shows. And the CBC shows lymphocytosis. And so the overlap of splenomegaly and lymphocytosis is limited. It's really down to three things. Is it infectious mononucleosis, EBV or CMV? Is it lymphoma, or is it drug-induced hypersensitivity syndrome, DIHS? Those are the three things that really notoriously do this. And the question is, do any of them cause a kidney dysfunction? And the answer is, yeah, of course, any of them can cause prerenal AKI, and the link between them and kidney dysfunction also extends into intrinsic renal kidney dysfunction. But I think the most concerning hypothesis would be this person has had 30 pounds of weight loss, they have splenomegaly, and they have a splenic infarct. Could they have a lymphoma? And that's where another crystal, uric acid crystals from tumor lysis syndrome, becomes really important to assess and to measure. So I think unless this patient is found to have mononucleosis, which is a very reasonable explanation, especially CMV, for a young middle-aged adult to have acute fatigue and splenomegaly, you'd really worry about lymphocytosis, about lymphoma. So for me, your approach to splenomegaly is superb. It's really helpful to have that comprehensive approach. The splenic infarct often tucks right into the splenomegaly as a consequence of it, though, as you said, you want to make sure that you're not dealing with endocarditis, which is a very morbid cause. And lymphocytosis equals EBV, lymphoma, or drug-induced hypersensitivity syndrome, all of which cause splenomegaly. So I think flow cytometry on those cells will be very, very important to see, are they monoclonal or polyclonal? Hopefully this person has mono, but the concerning thing would be that they have a lymphoma.
I just wanted to share one thing. The link that I was trying to remember, which was that brought the endocarditis to my mind, is because I had a very similar case, like a diagnostic mystery. And one of the hypotheses was Bartonella endocarditis causing pulse-immune glomerulonephritis. And that's what ties it all together in my mind. I was trying to remember the link. I don't think it's this case. It's interesting that splenomegaly can cause infarct, and I can see that happening. So thank you.
Great point. I love it.
Yeah, no, that was a great thought. I was also thinking about endocarditis because I remember when LT came to our medical school, presented a case of spleen infarct, like the final diagnosis was acute fever-related endocarditis. But anyway, this patient, the day team didn't get a TEE, so I guess they didn't feel there was other evidence. So for the test that we did, the HIV was negative, EBV panel, EB mono was negative. They also sent an EBV panel, which showed VCA IgG is high, but VCA IgM is negative. And the acute hepatitis panel is negative. So on day 3, the creatinine continues to improve towards baseline. The mild LFT elevation also normalized, and platelet was 148. They got a duplex ultrasound. Not sure for what reason, was I think to further rule out concern for thrombus. I guess it showed no DVT, but a superficial venous thrombosis of the left greater saphenous vein. So they called hematology, and patient started on anticoagulation and sent hypercoagulability workup. Patient was actually discharged at that point, even though I feel like there's some lingering questions because the team never sent CMV. I was hoping they sent the CMV. Although I was also curious how common, because I was reviewing Prof. Red's video on mono, and it sounds like lymphadenopathy is something like, I think was something that they most of them have, but this patient doesn't have lymphadenopathy. Anyway, after the patient got discharged, the lupus anticoagulant came back positive, and the anticardiolipin and IgM was elevated, IgG negative, and anti-beta glycoprotein IgG, IgM are both negative. Yes, I'll stop here. I think after this, I only have one last aliquot, but as I mentioned earlier, patient is still in the process of following up.
Oh, very interesting. Yeah, I was thinking that the signal for me for cancer is growing stronger and stronger. I'm becoming more and more convinced that there's an underlying thing. I doubt this is a primary antiphospholipid syndrome. I do believe that we have something underneath, but to be honest, other than lymphoma, my list of differential diagnoses is pretty thin. What do you think, Rabih?
Oh, yeah, no, I think that this case is so awesome, and I'm so glad we won't have a conclusion today. It just reflects what real life is, and I hope, and you maybe in the next month, because I imagine it'll take a while to have clarity. But I think, Noah, we can say the tension is this, you just go down to the most defining feature of this case. It's lymphocytosis plus splenomegaly. And the truth is that is not an uncommon space to be in, especially if you're in primary care, where you're taking care of patients with mononucleosis, and they come in and they often will have splenomegaly and lymphocytosis. The vast majority of people with mononucleosis will have those two things. The reason that the primary care space, be it internal medicine, family medicine, doesn't hold too much attention is the patient's demographic. Most patients who get mononucleosis are young adults or young. And so when you have mononucleosis in an older patient, the calculus is different because the base rate of lymphoma is now high enough that it causes some angst. But if you change this patient's age to 27, is lymphoma possible? Of course, it occurs in all ages, but the probability is much higher with age. So this is a lifelong tension that people will have. And the thing that will be definitive will be if anything shows monoclonality, if the flow cytometry does. But if that's not available, then time will tell, because the vast majority of mononucleosis infections are transient infections in most people, versus lymphomas will not stop. You may say, wait, hold on, aren't there indolent lymphomas? But once a lymphoma declares itself as not being indolent enough to be asymptomatic, then it will not stop. And for me, ironically enough, the kidney is the biggest tiebreaker. I would not expect the kidney to be healing by itself with little supportive therapy if a lymphoma all of a sudden decided to chew through this person's kidney and cause such devastation. But that leveraging the kidney requires a little bit of knowledge on CMV in itself. So CMV is much more common than it would be otherwise in older adults with mononucleosis. So it's about a 90-10 ratio of EBV versus CMV in younger adults, but CMV is increases not quite to match EBV, but as a cause of mononucleosis. And I think knowledge about CMV here is that it tends not to cause a lot of pharyngitis, unlike EBV, tends to be more systemic. And just like the other virus with the C, COVID, has a high rate of thromboembolic disease. It's one of the most hypercoagulable viruses we know of. In fact, episode number 4 of the Clinical Problem Solvers was Reza, or 3 or 4, one of those two. Reza presented a case of splenomegaly and PE from CMV. So CMV will cause clots. It will cause positive lupus anticoagulants. What would I do in this case? I think I would send a CMV test, send flow cytometry, and wait for the test of time. But now I would go back to the patient, pull up a chair, and grab some tea and ask him, tell me about your life 1 week ago. And if he gives me a whoppingly convincing answer. Like, I was doing great, I was feeling fantastic, I was all of a sudden I would be much more relieved. If he starts to say, you know what, now that I've been in the hospital this long, I'll tell you, I've just been adapting to not feeling well for a long time. That conversation would really sway my pretest probability. But I think though there isn't an answer, I think the patient is on a pathway for clarity. And I think that pathway will be, cancer doesn't hide when it shows itself this way, and the flow cytometry on the lymphocytes will be enormously helpful, as would a CMV. But honestly, if I'm guessing right now, which is good practice to do, it's a 60-40, but I think for me, the 60 is CMV.
Yeah, thank you so much, Rabih. I think I kind of know what to do next with the patient. I'm going to call the patient and have a conversation with him. But I do have the flow cytometry result. So I'll just give you the last aliquot, which is the follow-up of this patient over the next couple of weeks. Patient has seen PCP and the hematologist, getting some repeat labs. Patient continues to feel pretty fatigued. Same level of very much fatigueness. Epigastric pain has resolved. But so the flow cytometry showed polyclonal B cells, T cells with no antigen aberrancy, and there's a reverse CD4-CD8 ratio, no significant blast population. There's neutropenia and normocytic anemia. So he plans to follow up with repeat lupus anticoagulant labs in a couple of months and monitor his CBCs, and hematologists may consider a spleen biopsy or bone marrow biopsy if symptoms persist. Although I'm also curious how long, like CMV kind of mono could persist with, like him with symptoms like this.
I'd love for Noah to reflect. I just while you're thinking, Noah, I'll just ask you, if you happen to know what happened to his lymphocytosis. Do you have a follow-up percentage of those, or is that still in the works? Do you know?
Oh yeah, similar differential. There's still like 50% lymphocytes. There's some neutrophil decrease.
Okay, gotcha. Thank you. What do you think, Noah?
I mean, my mind is going two different ways right now, because, on one hand, I feel like this patient has enough history, has enough factors that we can explain all the symptoms to benign causes. And, CMV and other viruses, they can have lasting impacts in physiology for quite some time. So on one hand, I'm relieved, but on the other hand, I also feel like we don't want to miss anything with this patient, because we also have enough clues that tell us that something more serious might be going on. So, this is a patient I would follow up very closely, and I agree with the plan. For now, I don't think there's anything else to do. I mean, we could continue investigating him with more intensity, but I don't think that's the way to go. I think close follow-up, more clarification on like baseline status, and see if there's any other, extrinsic factors that's making him feel fatigued or feel this way is a good path to diagnosis, and just give him time and give his disease time to, fully express themselves.
Yeah, no, I love that. I think I think that's absolutely superb. And maybe one thing you can do before we hear from Mengyu and Leah is just to kind of reflect on your clinical reasoning journey in this case. And I think people will learn a lot from what you did about holding tight, and then jumping in when you got more data. And I'm curious to hear how that felt and how you reflected. In the meantime, I'll just share one fact, which is the sensitivity of flow cytometry is largely a function of the number of cells you're testing. And here we tested over 3,000 lymphocytes, none of which showed a monoclonal pattern. So the probability that those lymphocytes are malignant is low. However, you can have lymphocytosis as a paraneoplastic reaction to a lymphoma. So the lymphocytes themselves don't have to be aberrant. But I think the path is clear to this patient. You have to follow up, see how he feels, see what the counts are. But I am very reassured that none of those lymphocytes appeared to have any abnormal expression, which I think if I was 60-40 towards CMV, I'm probably now 80-20 towards CMV. It's so sneaky because we erroneously lump it into mononucleosis, but it has that one thing in common, which is that combo of splenomegaly and lymphocytosis, but presents so differently than EBV with much more diffuse center of gravity rather than EBV, which tends to be centered around the throat. So if we had just changed this case and said, oh, the patient had pharyngitis and cervical lymphadenopathy, I think the case for mono would be stronger in our minds. But I think this is a good example to remember, even if it's not the answer, that CMV does sneak up on patients in a more diffuse manner rather than EBV. But I'm curious, how is it having to stay non-specific and then dive in? How did that feel?
It's
Yeah.
hard. It's hard because
I think you muted yourself, but I think.
I'm sorry. It's very satisfying when you can look at the first aliquot and see like 3 different complaints and then come up with a very specific, very exoteric reason to explain them all. But it's also like very dangerous because, you know, you're setting up for a very big mistake. And I think this case was very good because we spent a lot of time, you know, trying to figure out what problem we're trying to solve. It was not clear, you know, until kind of the last few aliquots. We didn't know what was going on, and we felt comfortable not knowing and watching and waiting. And this is a new skill for me, you know. Usually I would dive in and try to list, you know, very specific etiologies. But it was a very, very nice experience.
I thought you modeled that so well, and I hope you continue to do that forever. And my final comment before passing the mic to Mingyu and then Leah is finally know, at least 80% know why the patient was sleeping when you met him, Mingyu, is because he probably has mono and is utterly exhausted and wiped. Having had it, it's so exhausting. I was asleep for basically 2 weeks. So hopefully he sleeps it off and he is much better. He does not have a lymphoma, but I think you always have to be vigilant towards that possibility. What was it like for you taking care of him? Or I know following him as the night admitting person.
Yeah, by the way, one reflection I had just now is like I probably should reorganize my aliquot a little bit so that the important information comes up a little bit earlier. But I guess it's the first time present in the CPS hour, although I would like to present more. But anyway, I think I reflected a lot with my intern, like, because one, there were so much things we learned during this diagnostic journey, like the intern I worked with that night, like we review like what causes splenomegaly, what causes lymphocytosis and atypical lymphocytes, and how infectious mononucleosis is diagnosed and what phase of mono are we observing, like how to interpret the test, and spleen infarct and lupus anticoagulant. Learned that it is actually commonly, if it's just anticardiolipin positivity, could be in the setting of acute infection like EBV, and like other infectious causes. One thing I wish we had done is to actually get in touch with the day team earlier and to make sure they send CME, but also actually what we can do is call the patient, which is probably not too late, to get that test scheduled. So I think like one important thing is like, I think being the challenge of being on night shift doing admissions, like sometimes you kind of have to flush out the symptoms, tease out the symptoms one by one until the true core problem floated in front of you. So kind of teasing out this AKI part and allowing us to get imaging, but also get the core problems.
Yeah, I think that's absolutely superb. And it's having done nights, it's so hard. And your job really is to make sure the patient just makes it during the day. And I think you more than did that. I would honestly say I would hope that you wouldn't change your case presentation at all, because I think the whole goal is to actually mirror and reflect what happens in real life. And I think VMR all too often tries to package a case to make it a fun, interesting story, which I think has its time and place. But I think more important is for us to really live the reality of what you lived. And I think it's such a tense thing to decide do scan or not scan this patient. And I'm glad we got to have that conversation. It's such an important thing to look at the diff. And I'm glad that you pointed it out after you gave us the CBC, because those things, if they're given to you and spoon-fed to you, you don't have to live with the tension of what it's like to not have them. And so I really appreciate you giving us that as an active exercise rather than a very passive one. So I hope you don't change. I really do. Thank you. All right, Leah, take it home.
Hi, so I have the honor of summarizing this great case. And honestly, I think, Noah, this was your first discussion, but from the beginning on, I loved how eloquently and structured your presentation or your discussion was. It was really nice to follow. So I will just start by saying we know that AKI is divided up into pre, intra, and post-renal. And it's easiest to first rule out the pre and the post, and then after check for intrinsic. So how do we do that? We rule out, we give fluids, see if it's better. That might be an indication for pre. And we do an ultrasound. So if there's any signs of obstruction, that can cue us into post-renal causes. And I think it's funny that we can say these are the 2 Ps we can rule out fast before we check the intrinsic, because later on we'll have the 5 Ps of intrarenal AKI, which are platelets, pigments, paraproteins, pharmacy, and pointy crystals. So lots of Ps going on in the kidneys, no pun intended. Then we had the D-dimer. So the D-dimer was kind of curious in this case because usually, okay, D-dimer, we think of PE, but it has a really low specificity. And in general, we had an unclear picture here in this case. So we had chest pain, dyspnea, AKI, and many other symptoms, and which we didn't know, are these confounders, what's noise, what's signal. And then we just said, okay, let's start with the basics, do an ECG, chest x-ray, fluids. You do have to rule out something like a PE, the most morbid causes, but then see fluids. Do we have any indications for what might be going on here? And I think in this case, we gave fluids, it got better. The electrolytes were not so disrupted. We were also thinking about, might this be a subacute kidney dysfunction that has just now kind of exacerbated? And then I think a really important point that was mentioned, when we talk about chronic kidney disease, it's usually an intrarenal problem, or actually always an intrarenal problem, because we have pre and post-renal causes that might make it worse, but CKD is usually because of a problem that is in the kidney. So lots of talks about AKI, CKD, what might be clues for subacute kidney dysfunction here. We also talked about sleeve gastrectomy, which is a type of bariatric surgery and can have several complications, among which anatomical, nutritional deficiencies, and hyperabsorption syndrome. But the main focus at the end of the discussion was the splenomegaly, which was kind of one of the first real informations we could get a hold of and then do more specific differential diagnosis off of it for the patient. And I divided it up into 3 things that were discussed: splenomegaly plus. So first we saw signs of infarction. Splenomegaly plus infarction. What can cause an infarction of the spleen? It's either an acute ischemic arterial event, or the spleen, it's also ischemic because it's too big, so perfusion is compromised, but it's because of autoinfarction due to splenomegaly. Then the second point, lymphocytosis. I really love the pearl that Rabih shared, that there are 4 causes that can cause both splenomegaly and lymphocytosis. So think of mono, so EBV, CMV, lymphoma, and DRESS. And then an atypical finding here was the atypical lymphocytes, which made us think, wait, could this be something monoclonal like a lymphoma? Or we also find atypical lymphocytes with mononucleosis. And then we thought through, what is more likely here? EBV, the age doesn't fit that well. We expected more in younger adults. And it's also more transient. So if this was really just acute and not really a long process, then EBV or mono would be more likely. CMV, interestingly enough, I didn't know that before, is more likely with age compared to EBV. So CMV a bit more common with older age, more systemic symptoms, hypercoagulable virus. And then the third point was the lymphoma, which you would expect in older age. So that's why we should pay attention here. This is a 47-year-old man. And then also it's progressive. So it gets worse. Now this we took a step back because he did get better with the fluids and he did fall asleep. So there are many things that made us think, wait, this might be a sick patient, but maybe not so sick patient. And then also lymphocytosis might also be paraneoplastic, which I just thought was an interesting pearl in the end. So in the end, we don't quite know what this patient has, but because we're still concerned about a malignant cause, close follow-up is what should be done with this patient. And that's how I'm going to end. There were many more things shared in this presentation discussion. Thank you so much for being here, learning medicine together. And I'm sure we'll all have a lot to reflect here and take away from this. Thank you for the case presentation, Mengyu.
Oh my gosh, I've gone exactly 2 weeks to the day without VMR, and I'm so glad I get to be back. Thank you, Mengyu, for an amazing case, Noah for an outstanding discussion, and Leah to top it off with such an eloquent summary of the teaching points. It was a real treat. Really excited to be back again tomorrow for RLR. Hope to see many of you here. Have a great day. Bye.
Thank you. Bye.